Hello, hello. Am I audible and visible, guys? Just give me a second.
You say I need interior.
Hey guys, can you see me and hear me? If so, see me and a hi and a hello. Hope you can. Okay. So welcome back, guys. So today I'm going to discuss a few slides, important practical slides. Some of you guys had sent me on Instagram that you wanted to have a look at these slides, and that's a primary reason that we are having the session. I'll definitely try to cover more of these things if it helps you guys. Do let me know at the end of the session, right? So today's slides, it's going to be a compilation of everything. I'm going to restrict myself to two important diagnostic point, maybe a two additional point, and I will show you a real life slide how you look in a microscopy in your college, but in the form of an iPad and a digital slide, right? So let's go ahead. So if I think quite a few of you guys have your exams upcoming in the August 1st, so all the best for that first, right? So this is the first slide. It's a granulation tissue, right? I want you guys to comment. Granulation tissue is nothing but a healing tissue, right? These are the 2 points which are required if you have to write in the practical exam. One is it's a proliferation of fibroblast with new capillaries. This is very, very important, right? The presence of numerous capillaries and fibroblasts within a loose connective tissue matrix is nothing but a granulation tissue, right? And like I said, do guys comment on this answer. What do you think will be the collagen present here? Because when fibroblast is present, they are definitely going to produce collagen, right? So what type of collagen will be there in granulation tissue? Granulation tissue will have collagen type 3. It changes to type 1 collagen when it becomes a scar tissue, right? Okay. Inflammatory cells will be a mixture. It might have an acute inflammatory cells, it might have a macrophage, it might have lymphocytes, and it might have plasma cells, right? So can I call a granulation tissue as a healing tissue? Is that statement right? Is the statement right? It is, right? So you will see granulation tissue all the time at the bed of an ulcer. Most of you guys in your colleges, granulation tissue will be seen in the bed of an ulcer only. That's how it's going to happen. I'm also going to show you an ulcer slide. At the bed or in the base of the ulcer, you will see this granulation tissue, right? So it's a classical slide of a granulation tissue. I hope the slide is visible for you guys. Okay, it's an epithelial tissue. You can see the skin here. Can you guys see the skin? What epithelium is this? Anyone? What epithelium is this? That's a stratified squamous epithelium, right? So the skin, if I follow through up here, can I say in this place, the skin is lost? Loss of skin or mucosa, we call it an ulcer, right? So this is nothing but an ulcerated area. Again, if you follow through, you're starting to have the skin again some place here, right? I'll zoom out for you guys. So here, from this part till this part, the skin is gone or the skin is ulcerated. You can see the skin here. At the same time, you can see the skin at this part as well, right? So in the bed of an ulcer is what you will see the granulation tissue always, right? Hello ASDF, right? Let's zoom in. I'm just going to zoom in this area. I'm going to zoom in further the area. I want you guys to tell what are you guys seeing? What are the structure? This one, these tiny spaces. Can I call them good amount of blood vessels? They do look like blood vessel. Yes, they are absolutely blood vessel, right? You zoom in here, you can see a clear-cut lumen filled with an RBC. Again, a lumen filled with an RBC. Here also you have lumen filled with RBC, lumen filled with RBC, right? In a loose connective tissue stroma, that's what I said. This is definitely a loose connective tissue stroma. You do have collagen in the stroma by default and obviously inflammatory cells, right? So this is how a granulation tissue looks like. Granulation tissue, first point, will always be seen in the healing tissue. It will be seen in the bed of an ulcer, be it in gastric ulcer, skin ulcer, anywhere in the body, right? And if you want to write 2 points, these are the 2 points. Proliferation of fibroblast, your blood vessels in a loose connective tissue stroma, all the finding we saw here, right? Good evening, Ekansh. Okay, and mixture of inflammatory cells. That's the first slide of a granulation tissue. Okay, the next slide. The next slide is a very simple case of a coagulative necrosis, right? Let's make it interactive. Answer the questions. Where do you see coagulative necrosis? We have done like 8-9 months of pathology. If you've been with me, you must have known definitely where do you see coagulative necrosis, right? You see them in all these solid organ infarcts. That's one. The most important thing is this. You can write where do you see them? All solid organ infarcts except brain infarct, right? Preservation of the tissue architecture or a ghostly outline. Let's assume this is a tubule, normal tubule. When this tubule dies, also it will preserve the entire outline. That's what I'm saying is in granulation tissue. If the outline is preserved, it's classical for an coagulative necrosis. In a liquefactive necrosis, you won't see the outline. Coagulative necrosis, outline will be preserved. Eosinophilic cytoplasm, intense peak due to protein denaturation. Again, these are 2 points I want you guys to write. Example, you can add on to any example. Infarct of any organ except brain, right? So let's have a look at the necrosis of a liver. I have a slide with massive necrosis of a liver. I'm just going to zoom this area. Before going to the slide, can anyone tell me what will be the color of necrosis in a biopsy? Pink or blue? Necrosis, pink or blue? Necrosis has to be pink, right? Perfect. Okay. Now let's go here. To understand this liver, you will have a biopsy finding written there. This is a liver biopsy, right? Now I'm just going to zoom in further. Can I say this cell, this group of cell here has blue color as well? They do have, right? So this is a live preserved cell, and rest everything here is necrotic, right? This everything here, if I have to annotate this, just give me a minute. This entire place here is necrotic. All these are necrotic tissue here, right? Perfect, Akash. Everything here, whatever you see pink, are necrotic. But at the same time, I'm just going to this necrotic area. Does it resemble that they are like lines here? Does it resemble that this necrotic tissue also has a preserved architecture? They do look like kind of rows of hepatocytes, right? So it's a preserved architecture. Look at this. Can you see that it's kind of the same hepatocytes present? This, but it's destroyed, right? So preserved architecture, pink color is classical for necrosis of any tissue. That's the diagnostic of coagulative necrosis also, right? That's a second slide. Just 2 findings. Ghost cells is important. Preservation of tissue architecture is very, very important. An example of any massive organ infarct, solid organ infarct, you'll have your coagulative necrosis, right? Let's go to the next. Fat necrosis. I'm sure you know one example of fat necrosis, which is your acute pancreatitis in the omental fat, and also have traumatic fat necrosis, right? So fat necrosis will have chalky white areas. This is gross, not microscopy. Microscopy, every necrosis will be only one color. Like I can't shed, it will be pink in color, that's all. So normal color of fat, how will a normal fat look like? Normal fat will be clear, right? We can't forget that. A normal fat will completely be clear. So obviously a fat necrosis, when this fat becomes pink in color, that's necrotic. Anywhere necrosis has to be pink in color. So a normal fat will be clear and fat necrosis area will be pink. Again, like I said, examples. One example, classical example is in case of an acute pancreatitis, the omentum has fat necrosis, or the peripancreatic fat. I'm going to show you an omental fat necrosis, classical case of an omental fat necrosis, right? At the same time, you can also have traumatic breast fat necrosis, or any like gluteal region. Any trauma to fat rich structure will cause fat necrosis, right? Now let's go and have a look at this slide. First thing, 2 points here which I want you to learn. Let's look at the normal fat first, and then let's look at the fat necrosis also, fine? Like Kant said, now normal fat will be clear. Can I call this an adipose tissue? How many of you are okay to call this an adipose tissue? Perfect. This is how a normal omentum will look like. Completely normal adipose tissue, round vacuoles, right? If you zoom in, even in the corners of the adipose tissue, you can see the nuclei. You see a nuclei here? It's nothing but a normal adipose tissue, right? So now, let's now look at the necrotic adipose tissue. When you look at the necrotic adipose tissue, again, is the outline preserved? Does it look like a adipose tissue? Round thing? But the only difference here is it's looking pink in color, right? So this part here, let me annotate for you guys. This part here, whatever you are saying in this circle, that is a necrotic adipose tissue or fat necrosis. Just to compare, look at the next slide. So look at the next area. I'll use a square. So look at this area. Whatever I have marked in square, that's a normal adipose tissue. Clear areas, transparent. And here, the same round structure is becoming pink in color. That's a necrotic adipose tissue. So this is a classical slide of a fat necrosis. This is how fat necrosis looks like. And 2 pointers to write. Grossly, you'll have the chalky white areas, saponification. 2 examples, pancreatitis, omental fat. That's like what we saw in the slide. And the breast traumatic fat necrosis, right? Perfect. Amazing, right? So let's go to the next one. Acute appendicitis. This is definitely, if you are having a practical on this slide will be there, because we expect you have to at least identify them. The first clue how to identify the slide is appendix. Grossly also you will see a tubular structure. Okay, the entire appendix can be put in a single slide. A tubular lumen is seen. That's what is appendix. And then you have the mucosa, submucosa, muscularis, serosa. Those linings will be there to identify it's an appendix. How do I say it's an acute appendicitis? The most important thing is neutrophilic. And the most important thing is I need to see neutrophilic inclusions in the muscularis propria and submucosa. This is very, very important. If you have neutrophils only in your mucosa, that's not an acute appendicitis. Please do remember. Sometimes we can have a fibrin and a pus on the serosal surface also, not always, right? Let's go and see if the slide of acute appendicitis works. First thing, can you see the entire organ? Yes, no, you can. Low power, if you see a complete round structure like this, that is a classical case of an appendix. That's all, right? Now let's zoom into this. Let's zoom into this. This is definitely an mucosa, right? This definitely is a mucosa. This part, can I say the mucosa is ulcerated? This part, the mucosa is ulcerated, and this part, it's a completely normal mucosa, right? And here, I'm just going to zoom in further. I'm going to zoom in further. Let's zoom in further. Are these inflammatory cells? Definitely. You are seeing good amount of inflammatory cells. All of these are inflammatory cells. Let's go deep down. You'll see inflammation not just in the mucosa. You have to see inflammation in the muscularis. This muscularis, this muscle layer, right? You zoom in, you'll have inflammatory cells. Can you see neutrophils? That's a perfectly lobed neutrophil, right? Look at this. A neutrophil. This is also a neutrophil. Bent nuclei. It's a neutrophil, right? All these are neutrophils. There are multiple neutrophils here. When you see neutrophils in between the layers of the mucosa, you call it an muscularis mucosa, you call it an acute appendicitis, right? I'll just zoom out again. This is the muscle layer. You have muscle layer, little bit whitish layer is the submucosa, and top of that you have the mucosa, right? Mucosa also have inflammation, but diagnostic point for me is inflammation in the submucosa and the muscularis mucosa, right? If you want an extra mark in an exam, add one more word to this. There's a worm called a pinworm. Pinworm is one of the parasitic infection which can be inward or seen in case of an acute appendicitis, right? Just an extra pointer, that's all, fine. Perfect. Let's go to the next one. Chronic cholecystitis. Chronic cholecystitis is only one important diagnostic point. The first point, Rokitansky-Ashcroft sinuses, that will be seen. This has to be in your slide description, right? So what happens is, let's assume this is a gallbladder. Most of the case of chronic cholecystitis will be associated with gallstones. Let's assume a gallstone is obstructing the neck of the gallbladder. What will happen to the pressure inside? Will it become more? Obviously, right? That increase in the pressure is going to push the mucosa into the muscle. That's your Rokitansky-Ashcroft sinuses. Outpouching of the mucosa into the muscle layer, right? Let's assume that I'll show you a slide as a classical finding. See, this is the gallbladder. The entire thing is a section of a gallbladder. This is the lumen. This lumen has more pressure, so it's kind of pushing the mucosa into the muscle. That's outpouching. It outpouches into the muscle layer of the gallbladder. We call it a classical chronic cholecystitis. That's an Rokitansky-Ashcroft sinuses, right? Let's look at the normal mucosa first, and then let's look at the Rokitansky-Ashcroft sinuses. Normal epithelium. What layer is this? Anyone? That's your classical muscle layer, right? Normal epithelium you have, and you have muscle layer here, right? Now have a look at this. Can I say this epithelial tissue here is kind of going inside, though not much, but definitely if you look at this, this is an epithelium, this is a gland, muscle. It's going between the muscles, right? It's being pushed. I'll show you a better area. There'll be multiple places where you can see this. Look at this area. Look at this area. Can you see? Yes, definitely. You see an epithelium, that's normal, but this gland here is on either sides covered by muscle, right? You have a muscle here and you have a muscle here. That's a classical example of an Rokitansky-Ashcroft sinuses. The epithelium outpouches into the muscle layer. That's a classical diagnosis of chronic cholecystitis, right? That's one. And obviously you'll see inflammatory cells. Inflammatory cells, your lymphocytic infiltration will definitely be seen in case of a chronic cholecystitis, right? If you want to write 2 pointers, this point has to be there. This is what I as an examiner will expect from an undergraduate, and maybe write more things. Etiology or classification can be due to calculus predominantly, or an calculus cholecystitis and an acalculus cholecystitis. I can have cholecystitis without the formation of an gallstones also, right? If you want extra marks, one variant of chronic cholecystitis where you will have your macrophages or the foamy macrophages inside your lamina propria. Inside the lamina propria, that's called as an cholesterolosis or a strawberry gallbladder, right? This is just for an extra point. If you want, you can add on to it. But please don't forget Rokitansky-Aschoff sinuses. That's diagnostic of a chronic cholecystitis, which is nothing but the pressure is pushing the epithelium into the muscle layer, right? TB lymphadenitis. And I'm 100% sure you must have seen multiple cases of TB. First, caseation. Completely necrotizing lesion, right? Central necrosis with surrounding epithelial cells and Langerhans cells. Acid-fast bacilli can be seen, may be seen, may not be seen. For a TB lymphadenitis, if you add the term periadenitis, that kind of will attract more mark. Periadenitis means not just the lymph node, the area surrounding the lymph node also will be inflamed. That's why lymph nodes gets aggregated together and you have matted consistency in TB lymphadenitis, right? Let's look at a tuberculous lymph node. It's a very classical image. Look at that, that's beautiful, right? I'll tell you what do I mean by periadenitis here. Can I say it's a capsule? This is a capsule, this is a lymphoid tissue fat. Capsule, 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 capsule. This is a capsule. Look at this area. Is it inflamed? It is inflamed, right? So it's not just sticking to the capsule. This is the lymph node. This is the capsule. Surrounding the capsule also you'll have inflammation. That's what makes them stick to another lymph node. Matted consistency, right? That's a classical image. Periadenitis, first feature. Second, beautiful pink necrosis. Entire structure is necrotic. Entire lymph node here is necrotic. What are these structures? These are your normal lymphoid follicles, right? You can see the normal lymphoid follicles. You can see such a beautiful central necrosis here. And if you come to the corner, let's zoom in. I'm sure you guys will identify the structure. What is this? It's marked as well for your convenience. What cell is this? That's a beautiful Langerhans type of giant cell, right? So here, Langerhans type of giant cell, you see a granuloma, you see a central necrosis, and you see periadenitis. These are diagnostic point in case of a tuberculous lymphadenitis, right? I'll zoom in outside again. Granuloma, central necrosis, Langerhans giant cell, and surrounding periadenitis, right? You have these 4 points. No one will expect more than this from you, right? That's all. It's a classical pink color tissue. That's a classical case of your tuberculous lymphadenitis, fine. Next, your fibroadenoma of breast, okay? So fibroadenoma here, it's one of the most common benign tumor which happens in the breast parenchyma. We have not completed fibroadenoma in your essentials batch, but just I'm sure you know a little bit about fibroadenoma by this time, right? It's a well circumscribed mass, encapsulated. These are all gross findings. This is not a microscopic finding. This has to be a gross finding. Microscopic can see, sometimes I may not see them. It's a biphasic tumor. It's fibro, it's adenoma. Two things are there, right? Which means you'll have an epithelial component, right? Epithelial component will be in the form of a gland, and fibrous component will be here, right? Just tell me, I want you guys to comment on this. What do you think is stronger? Epithelial component is stronger or the mesenchymal component is stronger? Epithelial component is definitely weaker and the mesenchymal component is definitely stronger. So what happens here is the mesenchymal component kind of compresses the epithelial tissue. So what happens in a fibroadenomas, the epithelium will become like this. It will become like a slit because they've been compressed by the mesenchymal tissue or the fibrous tissue, right? That's why the slit-like surface is very, very classical of a fibroadenoma. Stroma will proliferate as well as epithelium will proliferate, right? Let's go to the image. It's a classical case of a fibroadenoma breast. See, that's a compressed tissue, right? You can see that blue color, all the blue color are the glands which have been compressed by the surrounding stromal tissue. This is stroma. This thick, thin line is a compressed gland. Let's see if you can look at this area. Can you see that it's been compressed? It's a gland here. Yes, it's been compressed here by the surrounding parenchyma. The surrounding fibromatous component or the stromal component compresses the adenomatous component or the epithelial component. This appearance is classical of an fibroadenoma, right? There are two types. The type might not be required for you. Just remember, that's how a fibroadenoma looks like primarily, fine? Okay, perfect. IDC, infiltrating ductal carcinoma, right? Just have a quick look at IDC. IDC is the most common malignant tumor in the breast. For every malignancy, one thing you need is infiltration. You obviously will need an infiltrative growth. That's by default required. Malignant cells, which means you'll have all the 4 features of dysplasia. You can write pleomorphism, high NC ratio, mitosis, loss of polarity, and it's infiltrating the surrounding breast tissue, right? Again, I'll tell you how an infiltration looks like. Let's assume this is a normal breast parenchyma. So what you'll have here is, you'll have ducts and you'll have stroma in between. So normally what happens is, you won't see the epithelial tissue going into the stroma. If the epithelial tissue comes out like this, single cells or into the stroma, that's infiltration here. So infiltration in case of breast cancer is the epithelium going into stroma, right? It's not like skin, dermis, epidermis. It's a structure where the epithelium goes into stroma. We call it an infiltration, and it'll form irregular duct-like structures only because breast has ducts. The same duct lobular unit is what is going to see in the microscopy as well. Fine. Let's have a look at IDC image. Let's zoom this. Let's zoom this. Okay, first thing. Okay, now let's get used to the normal duct here, right? This is undoubtedly a normal duct with the central necrosis, fine. It's DCS, but as of now, it's not at least infiltrating. This part is a stroma, okay? This part is a stroma. Again here, we have ducts and stroma, right? We have ducts and stroma. Let's little bit zoom into this area. So can I say, see here you have a duct, yes? Can I say, then stroma also I'm having these blue cells. It's kind of infiltrating into the stroma, yes? You have a pink stroma here, you have cells here, you have stroma here, right? These cells are the infiltrating tissue, right? Let's zoom in here. Pleomorphic, not the same size, definitely. High NC ratio, more blue in color, right? I'm not seeing mitosis here, it will be there for sure. And loss of polarity. It's not looking like a duct at all, right? See here, I'm not seeing a proper lumen, right? That's a classical finding, right? All the 4 features of dysplasia, pleomorphism, high NC ratio, mitosis, loss of polarity, and you have this infiltration, you call it an IDC. Pranam Lalit, hope you're doing good. Okay, great. Next, about your CVC spleen. Fine, just give me a second. Okay, so CVC spleen is chronic venous congestion of spleen. So what happens in CVC spleen is, it's nothing but the portal hypertension is there. There's an increase in the portal pressure. Because of the increase in the portal pressure, so automatically it pushes and becomes, and the splenic venous congestion happens. Okay, that's the commonest diagnostic point. You will have sinusoidal dilatation, it's congested spleen, enlargement and congestion, and you'll have hemostadin-laden macrophages, and you will have a structure called as Gamma antibodies. Gamma antibodies also called as hemosiderotic areas, where you'll have hemosiderin, little bit of calcification happening in a structure of a splenic parenchyma, right? So there's a chronic venous congestion of spleen. Gamma antibodies, not a gamma antibody, right? Let's zoom this here. Let's zoom this here. Because of the congestion, all the blood kind of moves outside the circulation, outside the sinusoids. When the blood moves outside the sinusoids, it will die. When it dies, the iron cannot be reuptake because it's outside the sinusoid. It accumulates here and a little bit of calcification happens here. This entire structure is called as a gamma antibody, right? Definitely, can you appreciate the brownish color? You do see the brownish color here, right? You can see the brownish area here, and this is calcification. Brown areas plus calcification is diagnostic of a gamma antibody, right? Okay, all these are gamma antibodies. Gamma antibodies, and obviously the sinusoids will be congested. There's no doubt that in that. It's a bit difficult for you to appreciate them, but still, all these are sinusoids here, which are definitely dilated. All these are sinusoids here, they are definitely dilated. You won't see a sinusoid this big normally, right? All these sinusoids are definitely dilated. Look at them, they are definitely dilated, right? So dilated sinusoids is definitely a dilated sinusoids, right? So congestion happens with sinusoidal dilatation and hemosiderin-laden macrophages and the gamma antibodies, which is the accumulation of hemosiderin calcification happening due to the extravascular RBC, diagnostic of a CVC spleen, fine? Okay, squamous cell carcinoma. So you guys shared with me 2 things. One was squamous cell carcinoma, one was cervical carcinoma, right? Both of them are squamous in origin, so I'm not differentiating them. You will have undoubtedly keratin pearls. More keratin pearls they are called as a well-differentiated tumor, right? Sometimes you might have, if you go to higher power, you might have intracellular bridges. So you'll have bridges like this. This also tells me it's of a squamous epithelium. These both are diagnostic of an squamous cell carcinoma. Obviously, like we already discussed, invasion should be and must be there. That's by default, right? Let's look at squamous cell carcinoma. Okay, it's a beautiful squamous cell carcinoma, right? Keratin pearls are very much visible. Classical well-differentiated squamous cell carcinoma, right? All these are keratin pearls. Someone asked me, why do you have keratin pearls? It's a simple concept. The squamous epithelium is growing at a very fast rate because carcinomatous, producing more and more keratin. And the epithelium which grows is not letting the keratin shed, and it's kind of walling it off. It walls off the keratin, See, look at here. You have, let's assume this in keratin pearl. On all these sides here, you have squamous epithelium. You have epithelium here, epithelium here, epithelium here as well, right? It's not been allowed to shed because of its extremely fast growth. It's accumulating inside. That's a beautiful keratin pearl. World pink color appearance, diagnostic of a keratin pearl, and more amount of keratin pearls that they are very well differentiated, right? Let's try to see if you can see the intercellular bridges. They're a bit difficult to see, but let's see if we can appreciate them. Because keratin is more than enough for me to call it squamous origin, but yeah, I hope you can appreciate this. I'm not sure if you can see this. This area. Can you see that there's a flimsy lining here to the next cell? That's in classical intercellular bridges. Between two cells, I have pink lining, subtle lining. That's an intercellular bridge. Again, diagnostic of a squamous origin. Okay. Squamous papilloma, it's nothing but a benign tumor of squamous epithelium. It has papillary fronts with a central fibrovascular core. You might not see the pleomorphism, high ANC ratio. You might not see the invasion. Look at this. Classical papilloma. It is papillary in appearance, right? Okay. That's how squamous papilloma looks like. You will have good amount of epithelial proliferation, but you will not have atypia. No atypia, not much of keratin pearl because it's not a malignant tumor. It's not growing at a very fast rate, right? But yes, definitely in low power, it looks like a finger-like projection, like a papillary projection. That's diagnostic of squamous cell papilloma. Squamous cell papilloma, again, HPV could be one of the important causes of squamous cell papilloma, be it genital warts. In genital warts, we call it condyloma acuminata, right? That's a classical finding of squamous cell papilloma. Fine. Next, melanoma. We will read more about melanomas, papillomas, and basal carcinoma when we go to your your dermatopathology chapters, right? So melanoma has multiple subtypes. Melanoma is one of the greatest mimicker, right? It can have very large pleomorphic cells. Nucleoli is very classical of melanoma with melanin pigment. It can spread longitudinally, pagetoid. It can become big and grow like a nodule, right? There are many variants of it. A pagetoid spread, a nodular melanoma, amelanotic melanoma. Like I said, we'll discuss more about subtypes when we come to your dermatopathology, right? For now, if you have any slide with good amount of melanin pigment with very weird cells, call it an amelanotic melanoma, melanoma, that's all right. So this is a polypoidal melanoma. Look at this. The beauty here is the skin is very low. If you can look at this, this is skin here. The tumor is extremely big, right? So vertical growth phase and horizontal growth phase are two things in melanoma. Look at this part. Can I say you are seeing pigments, right? Too many pigments in the skin along with such a huge growth, undoubtedly it's melanoma. There are multiple subtypes of melanoma. Sometimes it might be a bit difficult to look at the subtypes. I'll just zoom in further. The classical thing about melanomas is the nucleoli. Very prominent, right? Extremely prominent. Look at the cell size. Pleomorphism, undoubtedly pleomorphism. Such a big cell, such a tiny cell. Again, an elongated big cell. And most of the cell here has an amazing nucleoli here. I'm pointing out a nucleoli here. Nucleoli here, right? Nucleoli here. That's very, very classical. Clusters of cell, pleomorphic cell with nucleoli and melanin pigment. You can see lots of melanin pigment in multiple cells here. I'll zoom this cell. Do you accept it's melanin? It is melanin, right? Let's go to the lower power. You can see much more pigmentation here. Look at this. All these are melanin pigments here, right? So you see pigments, you see a very pleomorphic epithelium, you call it a malignant melanoma, right? Melanoma is a spotter. Color in skin, you have to go for melanoma. That's all. Fine. Okay. BCC. So I'll draw a BCC, then we'll look at BCC. BCC is basal cell carcinoma, which comes from the basal epithelium of epidermis. So what happens is the tumor kind of grows like this. It grows like nest. First thing is you'll have tumors in the form of nest, right? With peripheral palisading. That's very classical. In the nest, if you look at the corner, the cells will look like this. Because basal epithelium is also palisaded, right? Nests of cells in the dermis with peripheral palisading, diagnostic of BCC. It's one of the cancer which very, very rarely spreads, right? This is a classical slide of BCC. Let's go and have a look at it. Okay, that's a classical nest, right? Lots of nests of cells in the dermis as a classical sign of a basal cell carcinoma. If you look at this, that's a nice palisading, right? In the nest of tumor cells, where will you see the palisading pattern is in the corner, right? This is a nest of tumor tissue. Look at this corner. All these cells are more or less parallel to each other, right? Look at the corner. They are more or less like this. They are more or less oriented this way, more or less parallel to each other. That's a classical sign of a basal cell carcinoma, right? Okay, let me zoom out here. Let's go and look at palisading in some other place if we can appreciate that. Look at this. Corners. Just look at the cells in the corner. All of them are oriented in this direction. Here also, all of them are oriented in this direction. That's a classical peripheral palisading. Look at this. That's a very classical peripheral palisading, right? Peripheral palisading, nests of tumor cells in dermis. That's diagnostic of a basal cell carcinoma. Okay, perfect. Next, papillary carcinoma thyroid. Or obviously, papillary will be there. That's the first finding. Next is orphan Annie eye nuclei. Orphan Annie is a name given because of the nuclear appearance. Normally, nucleus will be blue in color. Here, the nucleus will be clear and empty with a central clearing. It looks like an eye of an orphan Annie. Orphan Annie is a cartoon character. Since it looks like an eye of an orphan Annie, the nucleus is completely empty. We call it an orphan Annie eye nuclei. Any papillary tumor will have some of more bodies. This tumor also will have some of more bodies, right? Don't forget orphan Annie. That's a classical marker in case of papillary carcinoma thyroid. Okay. First, low power papillae. There's no doubt it's not a papillary, right? It's undoubtedly a papillary. You can see the multiple papillary fronts, right? Let's zoom in here. Definitely they're papillae. Let's zoom in here. Let's zoom in here. Orphan Annie can be seen in a high power image, right? Let's zoom in further. I'll go to a different place. Look at this. Look at these areas. Can I say the nucleus is not blue? It's clear, right? It's too much crowding happening, but definitely predominantly clear nuclei. Maybe we'll go to a thinner area where we can appreciate it much better. But almost every place, wherever you see the nuclei, they are more clear. That's diagnostic of an orphan Annie eye nuclei. Okay, let's zoom in this area. Look at this. That's an optical clear cytoplasm. Sorry, nucleus, right? It's a clear nuclei. Look at this, a clear nuclei. A central clear nuclei, all the chromatin going to the periphery. This is considered to be a formalin artifact. It's diagnostic of an orphan Annie. There's an orphan Annie, right? Most of the nuclear cells will have an orphan Annie appearance. Center clear, peripheral alone is being blue in color, right? As a classical appearance of an orphan Annie, this is a kind of pseudomonas calcification starting in this area, right? You'll have papillae, you'll have pseudomonas bodies, you'll have orphan Annie eye nuclei, and definitely is the most common thyroid cancer seen across the thyroid neoplasm. Like 70 to more than 80% of them are papillary carcinoma thyroid only. Fine. Okay. Hodgkin's. Hodgkin's is difficult to identify for an undergraduate. If they are keeping a Hodgkin's lymphoma slide, if I am the examiner, I will focus one area and ask you to look at it. Same goes for the blast, the Oyer rods, because it's a bit difficult in an exam to identify them. But I'm 100% sure by now you know the slide number of Hodgkin's lymphoma, right? Right, theoretically, you will see RS cells, large binucleate cells with an eosinophilic nucleoli. Background inflammatory cells is very, very important. But don't try to diagnose them in a microscopic slide. It's a bit difficult because if you're not used to it, you'll not be able to identify the RS cells clearly, right? Let's look at this. It's a very, very dense tissue. You have to zoom in RS cells to look at it carefully. Is it binucleate? Okay, this is around 80x, right? And only in 80 to 100x power, we can see them. The background lymphocytes, small round blue cells. This is a classical binucleate RS cell. A classical RS cell. I have marked it for you. I'll give this slide for you for a later viewing. You can just have a look at all these slides. Most of the things are marked here. Let's go and have a look at it. It's written that we see a mononuclear RS cell here. That's a beautiful mononuclear RS cell, right? It's a single nucleus, not binucleate, a very prominent nucleoli. Please apologies for this color. It's a very thick slide, so it's kind of not looking like a pink eosinophilic nucleoli, but RSL will undoubtedly have a eosinophilic nucleoli only, right? That's how an RSL looks like, a classical appearance of an RSL. Look at this. This is also an RSL. You have multiple RSLs here, right? All of them are mononuclear RSL. Such a prominent nucleoli that's diagnostic of an Hodgkin's lymphoma, but it should be marked, otherwise it's difficult for an undergraduate to pick up an RSL. Okay, few more things. Gastric adenocarcinoma, like every other adenocarcinoma, will have infiltration. I don't know which slide they showed you because there are two slides in adenocarcinoma. One is your intestinal type. Intestinal type of adenocarcinoma will definitely have well-formed glands, and the glands will be infiltrating, right? Other thing is your diffuse type of an adenocarcinoma, where you'll have signet-ring morphology of cells. When you have signet-ring cells, which called a diffuse type of adenocarcinoma, I'm just showing you an adenocarcinoma of stomach, which is of an intestinal subtype. That's all, fine. Again, just for understanding, you have your hello Sajid, I'm good. Hope your third year is treating you well. Okay, you have an overlying epithelium here. It's a normal gland. Let's look at this. It's infiltrating the submucosa. You can see the glands here. There's a gland. These are muscle fibers, right? You can see a gland in the muscle fibers. You can see gland even deep within the muscle fibers. That's a classical infiltration, right? So obviously it's a classical case of an intestinal type adenocarcinoma. Glands, 4 feet of dysplasia, and infiltration, you call it an adenocarcinoma. That's it. Okay. I just want some of your friends gave this Mridula like a few slides for the upcoming exam, so I'm just making a video. So hopefully it will help you guys, right? Just few more words about hyaline degeneration. Anything pink, I'm not sure of what it is made of. It's hyaline. Hyaline has multiple different examples. One of the classical example here is an hyaline membrane disease seen in case of an ARDS of lung. You see hyaline in case of an blood vessel. So you call it an hyaline arteriosclerosis, right? Arteriolosclerosis, right? So these are few examples of your hyaline things. So I'm just showing you an hyaline membrane disease of a lung. I hope the slides opens up. Okay, I think there's an error here. It's not opening up. Fine, let's ignore it, right? So that's your hyaline membrane disease or just an hyaline degeneration of any tissue here, right? So I've covered close to 18, 19 slides here. I'll call the session off. This is for the exam going students who have the upcoming exams. I think SUM Hospital Bhubaneswar has that. All the best for every student who's attending the exam. If you require anything, ping me on Instagram and we'll try to keep this a little bit more close to your university exams, right? I'll make sure we'll start the foray early. We'll start the revision early. Your second year pathology is due. I'll take care of it, right? Take care of the other 2 subjects, right? That's more than enough. I'll have a proper schedule thing for you. Revise them. Read with me. We'll take care of the theory as well as take care of the practical slides as well as gross and any test what's there for you guys, right? So thank you for your time, valuable time. See you soon. I know you're in a hurry for your exams, and let's sign off. Okay. If there's any more queries, do ping me in your Insta. Fine. Thank you.